maybe it's lack of confidence really. You're from Somalia, you entirely spoke Somali. We never, some people learned English if you're in a private school, but now most of us speak Somali.
Yeah.
Coming here, then you have the culture shock, it's just education-wise. And Africa and Britain cannot be the same. You guys are too fast for us. So it takes us a lot of time to catch up with you people. So the biggest barrier is language.
Yeah, and for example, because the system is different here to other countries. For example, in Iran, there is not a proper sort of health service there. So people who come from Iran may not know that in the UK, women after a certain age can access regular breast screening for cancer. So if they don't know that, so you can understand that it will cause problems later. They can sort of develop cancer without knowing, or they cannot stop the cancer at early stages. So this is a problem of lack of awareness about the health service in the UK.
GP is doing his role, consultant doing his role, so it's up to the family to balance everything we access and when we access and how. They talk to each other, but it takes ages, take months. So that is one limitation, but it's how the model is setting up here. And I think everybody complains it's too long until we access the service to GP, to the specialist.
Number one, if they don't have the awareness about something like breast cancer or something like that, or even other private part, and they don't know is why they got right to ask for a female doctor. And second, even if they found out, they don't have the language to ask for.
We very much work with the poorest people. We start with who are the poorest people that have the least, and that's where we start. So medical services and access to medical services is absolutely vital to what we do.
People don't know actually how the system works. They wait until everything gets really bad. So to use the facilities that are available within NHS is a big issue.
To coordinate all these in one hand is what I miss. Say, okay, Alex 2010 and Alex 2015. Nobody will know. Only us we collect. And not only we collect what is here, we collect also what is back home.
I will find some of them, they haven't seen their doctor for 2 years.
We have a lot of ambulance calls here because of ill health, epilepsy, bruises, heart attacks, the whole range of things.
For example, we also run a smaller project focusing on, say, heart disease, translating information from English to Farsi, or running workshops, such as healthy eating, as Nilufar has been saying.
And with the volunteer center that offer kind of link and clear the path within what is available in the community, what the information you can access, what kind of project you get involved, and what kind of support you can have.
If there's a Somali person in the mental health unit, we go and we visit them. We talk to them and we kind of assure them we're family, we're there. When they come out of the mental health unit, they come to the center and they kind of provide, like we become a family to them.
Every few months we have the NHS TB mobile unit here, and every person that wants to have dinner here has to go through the mobile lab in order to have their dinner to be screened. It's a public health issue, and it's very well received by the people here. Our jobs program is also very important because we work with migrant workers. A lot of the time they need to be registered with a GP. New people come here, they don't speak English. They speak a variety of languages, and they need someone to mediate on their behalf that knows the English medical terminology in their language so we can give the right diagnosis.
National Health need to work closely with faith-based organizations and centers where it's dealing with grassroots people, such as many of the people now like considering certain alternative medication, and some of them it will find it, you know, it is easy if it is really done under the National Health Service and under their supervision as well.
Ideally, we would have access to translator ourselves, because as soon as we say, okay, we refer you to psychologist, or you can go and see your GP, you can ask for a translator there. But it's hard to ask for translator there is an issue, because when you don't know language, you don't know what to ask for.
Maybe polyclinic will be a solution in long term, and I can, you know, hold my anxiety for the future years on Alex's medical care.
We do a consultation room. We're going to have a bed there, and we're asking Hammersmith and Philippi City to give us a nurse once a week or maybe twice a month, so that you can, you know, educate people on. Some people maybe don't want to go to hospital and they have questions, and also we want to educate people on sexual diseases and stuff like that, and we want to be able to be teaching people about family planning.
But there's a long way to go. As we all know, healthcare is one of those really high-cost provisions, and poor people in poor circumstances, hard to reach, tend to be at the bottom of the heap when it comes to treatment and diagnosis. So I just think there's a lot more potential for the PCTs to use voluntary organizations in their existing role. It doesn't take lots of money or anything like that. It does take some money, and it takes facilities. And there's a lot more potential for using voluntary organizations. A lot more.
Actually stops them to go and find out what is happening outside and use the services.